So the problem in acute kidney injury first. So what is the problem in acute kidney injury? In acute kidney injury, you need to know that the problem is that you have loss of kidney functions, at least 90% loss of kidney function. It can be 60 to more than, it has to be 90% loss of kidney function. Sometimes textbook may say more than 70% of the loss of kidney functions. Is it clear? But it is most of the time taken 90% loss of at least 90% loss of kidney function. Meaning that what? Meaning that it is, if you have the kidney, let's say you have two kidneys. Is it clear? So let's say that you have two kidneys as such here, and then the kidneys are made up of multiple nephrons. So let's say that the kidneys are made up of multiple nephrons inside. Is it clear? So let's say that these kidneys are made up of multiple nephrons. Is it clear? So let me add some two others. So this kidney is made up of 1, 2, 3, 4, 5 nephrons, and this kidney is made up of 1, 2, 3, 4, 5 nephrons. So we have 5 nephrons in each of the kidneys. Is it clear? Now we need to know that what, when they say that in acute kidney injury, means that what, let's say that the total nephron in both kidneys is going to be 10. Is it clear? In acute kidney injury, at least 90% loss of nephron function, meaning that what, 1, 2, 3, 4, 5, 6, 7, 8, 9 nephrons at least should not work in order for you to say that there is acute kidney injury, or the function of 9 nephrons at least have reduced. It's either the function of 9 nephrons has reduced, or the function of 9 nephrons are not working. Is it clear? So those are the points that you have to know for acute kidney injury. Is it clear? So sometimes people may say 70%. Is it clear? That is 7 in 10 and have reduced their function. Is it clear? Now, in the case of chronic kidney disease, this is a point that you need to understand very well, because you're going to use that in the management of chronic kidney disease, and it's going to make you understand the role of ACE inhibitors and ARBs, that is angiotensin converting enzyme inhibitor and angiotensin receptor blockers, in the management of acute kidney injury and chronic kidney disease. So this is going to be a very crucial part in your understanding to that. Is it clear? Now let's go for chronic kidney disease. In chronic kidney disease, you need to know that what, there is loss of only some. Is it clear? Because you need to know that at the beginning of chronic kidney disease, you just have the loss of some nephrons. So generally, the some nephrons just start with 1, meaning that what, let's say that you just have the loss of this 1 nephron. Is it clear? At the beginning, both of the kidneys were receiving perfusion from the aorta. Both kidneys were receiving perfusion from the aorta and having the venous return from the vena cava. Is it clear? So let's say that they were receiving perfusion from the aorta, both kidneys. Is it clear? Now we need to know that what, it is going to perfuse. So since this one here is not working, normally there are 10 nephrons that are supposed to be working. Now 9 are remaining. So when there is perfusion of the 9 are going to work for 10 perfusion. Is it clear? Is it clear? So what is going to happen is that this is going to result to overfunctioning of the 9 nephrons. Is it clear? Overfunction of the 9 nephrons. So since overfunction of 9 nephrons occur, one of the 9 nephrons again is going to be not functioning, and it may be symmetrical. So one of the 9 function is not functioning. So you are going to have 8 in 10 that are going to be working for the 10 normal nephrons. Is it clear? What is going to happen is that since they hyperfunction again, they are going to have what? You're going to have again overfiltration inside the remaining 8 nephrons. Since you have overfiltration inside the remaining 8 nephrons, it's going to kill again another nephron, resulting to damage of another nephron again because of the hyperfunctioning of the hyperfiltration of that particular nephron. Is it clear? So all that is going to result to a vicious cycle. So at the beginning you have a damage of one nephron, but it is senile. It is clear. Senile means, or it is senile, it is not visible. Is it clear? Senile means that it is not visible. Is it clear? So you have it, it is occult, it is not visible. So you have it is and it is silent. So you have it, you are going to have the destruction first of one nephron, which is silent. Then you have the destruction of a second nephron. Because of the overperfusion, you have the destruction of the next nephron. So all that now is going to result at the end point from a stage 1 acute kidney injury to a stage 5, from a stage 1 chronic kidney disease to a stage 5 chronic kidney disease. This is how you have the problem. This is actually the problem inside the chronic kidney disease. Is it clear? So that's why in chronic kidney disease, in order to prevent further, is it clear? In chronic kidney disease, in order to prevent further hyperperfusion of the nephron, you instead have to use ACE inhibitors. Is it clear? Why? Because ACE inhibitors are going to function by doing a vasodilation at the level of the efferent arteriole. So in this diagram, this was the afferent arteriole here, and this was the efferent arteriole. What happens is that ACE inhibitor or angiotensin converting enzyme inhibitor is going to do vasodilation at this level. When it does vasodilation at this level, the blood flow is going to easily bypass the glomerulus in order to reduce the filtration. It means that what? It means that the other remaining, let's say that we have a destruction of 2 nephrons. It means that the other remaining 8 nephrons is not going to work for the 10 nephrons, but is instead going to work for only 8 nephrons. Is it clear? It's not going to work for 10 nephrons, but it's going to work for 8 nephrons in order to prevent the damage of the remaining nephron. That's why there is a role of the management of ACE inhibitor there is a role of the use of ACE inhibitor in the management of chronic kidney disease, but not in acute kidney injury. In case of acute kidney injury, what happens is that you have a direct loss of at least 9 of them. Is it clear? You have a direct loss of at least 9 of them. Is it clear? Since you have a direct loss of at least 9 of them and it is an acute event, never use ACE inhibitor. Is it clear? Because when you use ACE inhibitor is not going to protect the last nephron, but is going to kill the last nephron. And also, you need to know that when you have an acute kidney injury, these other nephrons here are not dirt, they are just damage. And using an ACE inhibitor is going to prevent their perfusion. Is it clear? All these 9 nephrons here are not dirt, they are instead damage. But in chronic kidney disease, when one nephron is not functioning, it is death for life. In acute kidney injury, the 9 nephrons are not dirt, they are only damage. So using an ACE inhibitor in that case is going to worsen the damage because it's going to prevent again the filtration of those nephrons. That is going to completely destroy the nephron and not just damaging the nephron. That was the first case. So that's why acute kidney injury, never use ACE inhibitor. It is only used in a case of a chronic kidney disease. Is it clear? So we are going to evaluate now the other reason why we are going to use ACE inhibitor, where we are going to visualize the management. Thank you.